This 75-year-old man sustained a minimally displaced fracture of his distal left radius about 3 months ago. Several weeks ago, he noticed inability to extend the interphalangeal joint of his left thumb. This is the typical presentation of a rupture of the extensor pollicis longus tendon in the region of Lister's tubercle. The 3 incisions for a standard extensor indicis proprius tendon transfer to reconstruct the EPL tendon rupture are shown. Through this incision, the distal stump of the extensor pollicis longus tendon is identified and a tenolysis of the distal portion of the tendon is performed. Through a transverse incision just proximal to the MCP joint of the index finger, the EDC and EIP tendons to the index finger are identified. The extensor indicis proprius tendon is almost uniformly on the ulnar aspect of the EDC tendon to the index finger. Through another transverse incision at the base of the index finger metacarpal, the extensor indicis proprius tendon is identified proximally just distal to the extensor retinaculum. Once the EIP tendon is identified in both transverse incisions, it is transected distally, just proximal to the MCP joint of the index finger. The EIP tendon is dissected away from the EDC tendon to the index finger, and with traction on the EIP tendon through the proximal incision, the EIP tendon is passed from the distal incision to the proximal incision. A subcutaneous tunnel is dissected from the incision over the base of the thumb metacarpal to the transverse incision at the base of the index finger metacarpal, so that the EIP tendon can be transferred subcutaneously into the incision at the base of the thumb metacarpal. In this situation, the EIP tendon remains in the 4th dorsal extensor tendon compartment. Alternatively, the EIP can be retracted proximal to the extensor retinaculum and then transferred directly in a straight line superficial to the extensor retinaculum to the base of the thumb metacarpal. The distal stump of the EPL tendon is resected, and with traction on the distal EPL tendon, there is excellent extension at the MCP and IP joints of the thumb. Prior to suturing the tendon transfer, the distal stump of the EIP tendon is sutured to the remaining EDC tendon to the index finger to prevent any lag of the index finger. The 2 transverse incisions are also closed prior to the final tensioning of the tendon transfer. Provisional tensioning of the EIP to EPL tendon transfer is performed by retracting the EPL tendon to produce full extension at the MCP and IP joints of the thumb, and then estimating the resting tension of the EIP tendon. A couple of sutures are then inserted before performing a wrist tenodesis effect. With the wrist in extension, the thumb should easily flex across the palm. With wrist flexion, the thumb should come out into full extension. The most refined technique of adjusting the tension in an EIP to EPL tendon transfer is to perform this under local anesthesia at the end of the procedure. The exact tension on the tendon juncture can then be easily adjusted by having the patient actively flex and extend his thumb under the local anesthetic. 5 weeks post-operatively, the patient demonstrates excellent flexion and extension at the MCP and IP joints of the thumb and has symmetrical extension in his left thumb with his normal right thumb.